Hi everyone, my name is Sarmen Sarkissian. I'm a hematologist oncologist in the Los Angeles and Ventura County areas. Today I'm going to be presenting updates in cancer screening for various malignancies. So just before we get started, I just wanted to sort of reiterate which malignancies we do have screening protocols for that are validated by data and supported by various societies across the country, and malignancies that we do not have standard screening protocols for. Importantly, the cancers we do screen for, colorectal cancer, prostate cancer, breast cancer, lung cancer, and cervical cancer, are all supported by various societies with guidelines with subtle differences in some of the nuances of testing or the tempo and the ages at which they begin and end. But importantly, they're all supported by robust data showing that the risk-benefit profile definitely leans toward benefit for screening. Now, the vast majority of cancers we do not screen for. Now, the vast majority not by raw numbers of patients affected, but by the sheer different types of cancer. So, for example, most solid malignancies, we don't have screening protocols for, at least in the United States. So, for example, head and neck cancer, brain tumors, stomach cancer, for example, we do not have approved screening pathways in the United States. Gastric cancer in particular, they actually do screen for in high-risk countries, including Korea and Japan. And Mexico should probably be implemented as well. Other solid tumors, sarcomas, for example, as I mentioned, brain tumors, head and neck cancer, we don't have an accepted screening modality for. The vast majority of hematologic malignancies, your leukemias, your lymphomas, some of your myeloneoplasms, including myeloproliferative disorders, myelofibrosis, MDS, plasma cell neoplasms, your multiple myeloma, you hear about them, but we don't have approved screening protocol. So I can't cover all of the um, five malignancies today, but I am going to spend a lot of my time talking about colorectal, prostate, breast, and lung cancer. So without any further ado, we'll get into it. So let's start off by colorectal cancer screening. So what is some of the rationale for starting a screening program? Well, first we want to identify pre-malignant lesions. These are going to be your adenomas, which are distinct from carcinomas. You want to detect them when patients are asymptomatic at an early stage because that drastically changes the treatment paradigm. We also increase the chance of curing these patients, and these have been proven through several studies to decrease mortality. There are other screening studies that have been done for rarer cancer, say gastric cancer, that show that it's pretty hard to prove that you can actually reduce mortality on a statistical basis. Other things to consider, organized screening has been shown to reduce disparities for people in lower socioeconomic status, and as we know, in second and third world countries, this is a big problem, and even in the United States. And importantly, some of the risks associated with colorectal cancer screening are simply due to the risks of the colonoscopy itself. By no means does it reflect some of the risks associated with the treatment that would occur. So how do we assess risk? All patients need an initial risk assessment to determine if they are at an increased risk for developing colorectal cancer. This should always be done at the first office visit for all patients who present to a primary care physician, and you want to reassess this about every 5 years or so. So patients who are at sufficiently increased risk can start earlier or obtain more frequent screens. High-risk patients include those with a personal and a family history of colorectal cancer. And you're wondering, what does it mean to have a personal history of colorectal cancer? Well, it simply means you had it before, and just because you had it once does not mean that you can't have it again. Synchronous lesions, two primaries have been documented, and I've seen a couple of those myself. And other things to think about, patients that have adenomatous polyps and other risk factors, say underlying Lynch syndrome, familial adenomatosis polyposis, these are important predisposing factors for colorectal cancer. So the next question is, well, what age do we start? For average risk patients, we have pretty strong evidence to show that you should start after age 45. And you should continue to screen until patients are about 75 years old, assuming that by age 75, they have about a 10-year life expectancy, which is generally the gap that we use between colonoscopies. You want to screen at least until age 75 for patients who are average risk. For the age group between 76 and 85, you can individualize it just sort of based off personalized discussions you have with patients. The next thing you want to do is you want to have a discussion about some of the screening tests that are available for these patients. Factors in individual patient preference, what are some of the value systems they have? What are the risks associated with each of these? The efficacy of each test? What are some of the resources available? And ultimately, how safe are these tests? Are you going to be doing a barium enema, a CT colonography, flex sigmoidoscopy, a full colonoscopy? How convenient are these for the patient, for the institution you're in, and the cost? Colonoscopy is going to be the most preferred every 10 years for most patients who are at average risk, where you have a clean colonoscopy, you have a good prep, and you haven't identified any premalignant lesions. FIT testing, screening for occult blood, should be done every 1 year on a single sample. Multi-target stool DNA, now these can be spaced out between 1 to 3 years, but they are slightly less preferred, not because they're inferior, but any positive result is already going to buy you a colonoscopy. So the general consensus is that, with a colonoscopy, as challenging as the prep is, if it's clean, you're good for 10 years. Computed tomography, which is not commonly done, is an option for patients who are at high risk of having perforation, or for those who simply don't want the risk of the procedure. I think it's a bit underutilized in my opinion, but it's still an option for those who refuse a colonoscopy. And if you look at non-compliance rates for referral, they are on the order of 30 to 40%. Other tests, sigmoidoscopy with FIT testing or with GFOBT, sigmoidoscopy alone, GFOBT alone, and capsule endoscopy. Barium enemas are essentially obsolete at this point. So, and then the next question is, what do we do after we have an abnormal result? Well, every positive screen has to be followed up with a colonoscopy if you did not use a colonoscopy initially. And afterwards, depending on whether a polyp is discovered, that's an adenoma or an actual cancer, a T1 or a T2, then you go on to. Now we're going to move on to the next topic. We're going to talk about breast cancer screening. So some of the screening strategies available, they really are, risk-based. So the greatest value is going to be for women who are most likely to develop breast cancer and for whom early treatment is going to be more effective than later treatment in reducing mortality. Screening strategies do differ based off the estimated risk of breast cancer. There's a lot of variables that go into it. And then how do we assess risk? For the majority of women are going to be average risk. And what does that actually translate to? Just about a 15% or just under 15% lifetime risk. Your high risk patients are those that are going to be above a 20% lifetime risk of developing breast cancer. Who are some of these patients? Well, a personal history of breast cancer. Just because you had breast cancer in the left breast doesn't mean that you cannot have it in the right breast, or a new primary in the left breast if you had a lumpectomy. Patients with a prior history of ovarian cancer, peritoneal cancer, fallopian tube cancer, certain genetic mutations, BRCA1 and BRCA2 are the first ones that come in mind, but now they've actually increased that repertoire of genes that predispose you to developing a variety of cancers, in particular breast, ovarian, pancreatic, to name a few, endometrial. TP53 mutations are going to be, that's the ultimate gatekeeper for cancer, and we can get into some of the biology another time. Prior history of radiotherapy to the chest. I mean, Hodgkin's disease is very common in younger people. So if they had any radiotherapy to the chest, their breast is high risk. So how do we factor in some of the screening approaches for average risk breast cancer? Again, to reiterate the definition, average risk, which is going to be most women, just under a 15% lifetime risk of developing breast cancer. So about a 1 in 8 odds. Age-based approach is going to be the best way to go. Average risk women, you're going to use that to guide your screening. If you're average risk, so under 40, no need to start screening. 40 to 49, you can sort of take an individualized approach. It really depends on how dense the woman's breast is, what their value system is, how anxious they will be with or without screening. Some people are very anxious without a screen. Other people develop significant anxiety leading up to the mammogram. It's really hard to predict unless you have that discussion with the patient. This is the golden age, 50 to 74, those 25 years. This is where you're going to see the peak of breast cancer. So routine mammogram is definitely recommended in this age group. Above 75, I mean, I've definitely treated a lot of women over the age of 75 for breast cancer. You can still do it as long as they have a life expectancy of at least 10 years. So average risk women, how frequently should you do mammograms? They've gone back and forth across various societies, but every 1 to 2 years is recommended. Do not incorporate ultrasound or MRI unless the radiologist specifically asks for it atop a mammogram. Do not routinely add it on, and do not routinely swap a mammogram for an ultrasound or an MRI. I don't care what the patient tells you. Next, breast exams. There's two types, CBE and BSE. Your clinical breast exam, meaning it's done by the healthcare provider, and your breast self-exam done by the patient. Unfortunately, I wish the data could show that it does make a difference. It's probably good common practice. It's not necessarily supported by high quality data, but it does add an extra layer of psychological relief, in my opinion, for patients. I think a lot of patients can feel neglected if it's not done. So it does add a sense of comfort. At most, if you feel something, it could be followed up with a mammogram or an ultrasound. And so I think there's definitely some intangible benefit if they cannot be proven to have a tangible benefit. Next group are going to be your moderate risk women, roughly 15 to 20%. Now you're translating to about a 1 in 6 to 1 in 5 odds. Who are these people? A prior history of breast cancer and a first degree relative, but without a genetic syndrome. No BRCA, no ATM mutations, no other mutations. And again, it's going to be the same modality as above. You just might want to start screening them a little earlier. Do not routinely add your ultrasound and MRI, and do not swap without a radiologist recommending it. Finally, your high risk patients, a small subset, but we have to make sure we try and capture these patients and know who they are. They have a higher than a 20% lifetime risk. Now, remember, you're just seeing 20% on the screen, 1 in 5. A lot of these women are going to be 30, 40%. I mean, try walking around knowing that you have a 1 in 3 odds, 1 in 2 odds of developing breast cancer. It adds an extra layer of stress in your life. They should be referred to a high risk screening clinic. All the major universities and tertiary care centers have it. You live in a more rural area, then you might want to think about adding an MRI on top of the mammogram. Some of these women are going to qualify for chemo prevention with medications like tamoxifen. Those with a personal history of ovarian cancer, peritoneal cancer, tubal, breast cancer, family history, strong family history of breast cancer, Ashkenazi Jewish heritage, mutations that are well documented to cause breast cancer, BRCA1, BRCA2, ATM, any prior radiotherapy to the chest. These are the women that are going to be considered high risk. And ultimately, what does a lot of this converge on? Well, how do we manage breast cancer? This is what we're trying to minimize um, patients' exposure to when they are diagnosed. The benefits of doing mammograms every 1 to 2 years is you're going to catch a lot of really early breast cancers. It's a little bit different than prostate cancer, where a lot of men could really just walk around with prostate cancer and not need treatment. I wish it was the case for younger women, but it's not. But we can at least minimize some of the therapies that we're going to use for these patients. Surgeries, essentially all patients will be offered surgery, whether it's a lumpectomy or a mastectomy takes into account a lot of their variables. The only women who can get away with not having surgery are going to be those with poor life expectancy, absolutely non-surgical candidates, which is rare for most people because it's a pretty benign surgery. It's generally done same day for most places. Radiotherapy, when are you going to get radiation? Well, if you get a lumpectomy, you're going to need radiation. If your margins are positive after surgery, you need radiation. And if you have any lymph node positivity, for the most part, you're going to need radiation. Chemo, systemic chemo, traditional chemo, where you have hair loss, nausea, vomiting, traditional chemo, not targeted therapy, not biologic therapy, not immune therapy. It's going to depend on the subtype of breast cancer. Some of your hormone positive will not need any systemic therapy because they're so slow growing. Your triple negative breast cancers, your HER2 driven breast cancers, absolutely. Anybody with lymph node involvement, absolutely is going to need chemotherapy. Biologic agents, really broken down to your HER2 targeting antibodies, and your immunotherapies are really just subtype dependent. But generally, the sooner you catch these things, the smaller they are, the higher the odds you can simply get away with surgery and maybe just one other modality. So, thank you. Now we're going to move on to the next section. Now we're going to move on to the next cancer, and that's going to be prostate cancer. So the first and foremost, what are some of the benefits and harms of screening for prostate cancer? Well, one, do we have any evidence? So the evidence shows that screening has at most a small benefit when it comes to prostate cancer mortality, and we'll cover why in a little bit. And mostly has to do with there's such a wide spectrum of behavior in prostate cancer that it's very hard to compare two people off the street. So we're going to balance screening risks. That includes false positive tests, prostate biopsies, the anxiety associated with a diagnosis or a possible diagnosis, overdiagnosing patients, and obviously the treatment complications. Shared decision making for most patients, very crucial. There's a lot of talk that happens across every culture, every age group about screening for prostate cancer. My uncle had a PSA check. My brother went through this. I was down at the golf course Bob had this done. Everyone, every man at some point above the age of 50, it's going to be part of your general conversation as friends and family get together. For average risk males, meaning you don't have a family history of any particular disease, cancers, let alone prostate cancer, physicians don't are generally not in favor or against prostate cancer screening. Does that really help? No, it just means the jury's still out. And will the jury ever be in? Not until we have a better biomarker method, to be honest, besides PSA and biopsy. So males who are candidates for screening should be engaged in shared decision making about whether they choose to be screened. And I think this is just a very important kind of conversation to have with patients. And me as an oncologist, I would probably err on the side of talking people slightly out of having unnecessary screens and biopsies for all the reasons mentioned above. Individual patient preference for specific health outcomes are a deciding factor in determining whether to screen for prostate cancer. And we're going to be talking about a lot of things. Are patients candidate for surgery? Would they want to have radiotherapy? Are they going to want to have androgen deprivation therapy, was essentially putting men into male menopause? At what age do we start beginning to screen? You're going to have to factor in a lot of things. Are they of African American ancestry? Do they have a family history of malignancy? What age are they? If you had an African American gentleman where he had a father and an uncle, both of who died of prostate cancer, this person does have to get screening. But if you had, say, an Asian male with no strong family history of any cancer or prostate cancer in particular, you could probably tell this patient that they can hold off on screening. So your average risk males initiate the discussion roughly at about age 50. Anyone with a known history of BRCA1 or 2 mutations, Lynch syndrome, they should start about a decade earlier, age 40. And that's just a very, very different type of biology, and we have special drugs that we use to treat these patients. African Americans in particular, as I mentioned earlier in the example, family history, you want to start somewhere around 40 or 45. So, how to screen? First thing, blood test, PSA, very simple. The test has been around for decades, and there's really nothing better than that. You could check every 1 to 2 years. I do think every 1 year is a bit on the extreme end. Now, obviously, if you get a hit above 10 or 15, you have to refer them for a biopsy. Your threes, four, or fives, you could probably wait up to about a year, up to 2 years. So, and you want to screen up to about age 70, or depending on what their life expectancy. If they're 65 and they have an NYHA class 3 or 4 heart failure, and you don't think they're going to live another 10 years, they have severe COPD, you could probably just stop screening at that point, as a random example. And then interpreting and following up on the abnormal findings. Abnormal PSA, repeat, confirm, refer the patient to a urologist. They need to get a proper discussion about a biopsy based off their age, their desires, value systems, and what the absolute value of the PSA is. So a 47-year-old African American gentleman with a screening PSA of 25 absolutely needs a biopsy. Your 72-year-old with a PSA of 5.1, repeat showing 4.9, not very different from 6 months ago, you could reconsider the biopsy. PSA is above 10, you're going to refer to urology, and they can decide on whether or not they want an MRI or not. PSA is between 4 and 9.9. Just repeat the test in a couple of months. And if your repeat PSA again is above 4, then you definitely want to refer to urology. DREs for physical exam characteristics, you want to look for nodules, induration, asymmetry. Now let's chat a little bit about prostate cancer management. Why do we screen, and why are so many people concerned about minimizing screening and minimizing the detection of prostate cancer? Well, it's because the management can leave a lot of relatively healthy people who would have lived a normal life with anxiety, stress, fear, and importantly, a lot of the collateral damage from the treatment themselves. How do we decide on how we manage prostate cancer? Well, it's very different from pancreatic cancer, for example, God forbid, colon cancer. We really factor in two things. One is risk based, and the other is life expectancy based. So, your risk profile is going to be based off of your surgical pathology report, how big the tumor was it invading the seminal vesicle, is there a lymph node involvement, and importantly, what is the Gleason grade? And a lot of times, we're not going to have a surgical pathology report. So, we're probably just going to have a clinical assessment, and we're going to factor in the patient's life expectancy. Are they 82 or are they 51, factoring in, the grade and the aggressiveness of the tumor? And then what are your main treatment modalities? Well, if someone's curable, surgery. So moving on to lung cancer, this I think is one of my favorite topics in the realm of cancer screening. So what's sort of the rationale behind screening? Well, lung cancer is the leading cause of cancer-related death in the United States. Smoking prevention does have a grander impact in reducing lung cancer associated mortality from screening. And importantly, low dose CT, which is such a simple modality, has actually been shown to reduce lung cancer morbidity and mortality. And I just cannot reiterate how underutilized this is, how patients just are not agreeable, and just the cost benefit analysis for me, in my opinion, as an oncologist, is absolutely amazing. And it's a shame that it's such a poorly utilized modality across the country. What are some of the risks and benefits? Active and former smokers who currently smoke should all be offered screening. The potential harms associated with low dose CT, essentially nothing in my opinion. False positive imaging. I mean, if I was a heavy smoker and I had a possible false positive, I mean, I would take that any day than having even stage 3 lung cancer, to be honest. And I'll get into some of that in a little bit. Screening for at-risk patients. So any adult between the age of 50 and 80, you want to have at least a 20-pack year smoking history. And this has come down when they initially approved this in 2015. They wanted a 30-pack year history. And interestingly, for former smokers, you have to have quit within 7 years before. Now they expanded it out to 15 years. So they really liberalized it, which I think is a good thing. Annual screening is like recommended with low dose helical CT. Insurances do pay for it. You can discontinue screening when the individual has stopped smoking for about 15 years or they have a limited life expectancy. And what's the rationale behind this? Well, two large randomized trials were actually able to show a reduction in mortality. What are some of the screening modalities that we don't recommend? Chest radiographs are just not sensitive enough. Now, obviously, if you are getting a chest radiograph and you see a possible tumor there, of course you're going to follow it up. But they're just not sensitive enough to pick up the small ones when done on an annual basis. Combining radiographs with sputum cytology, it's just not ideal. In general, cytologies have pretty low sensitivity. PET CT is pretty expensive. I think it would add value in a perfect world compared to just a CT with contrast. But, it's expensive. It's a bit more cumbersome. There probably is not enough radionuclide to go around in the world, given the sheer amount of patients that would potentially qualify. But for all intents and purposes, it is not the way to go. And absolutely no to total body MRI. I know they sell these in certain parts of Southern California as part of total body cancer screening, but it's not advised to do this on an annual basis. And importantly, smoking cessation. Nothing as simple and cheap as that. And why does all this matter for lung cancer screening? Well, a lot of people still smoke, and there's a significant smoking burden out there. But compared to all the other cancers we talked about until now, your prostate cancer, your breast cancer, colorectal cancer, I would say of all, compared to those three, lung cancer treatments are even worse. You're going to have the worst outcomes, and the treatments are brutal if you even qualify for some of these. So, what do they encompass? Well, surgery. I mean, getting a lobectomy is already hard enough for a lot of patients. Imagine having to do a pneumonectomy in some patients. I mean, your quality of life is drastically diminished if you even qualify for one. If you're a heavy smoker, you have underlying COPD, maybe you had a heart attack at one point, heart failure, you may not even qualify for a lobectomy. Second, did you catch the disease early enough, or did you wait until you're coughing up blood and you're not a surgical candidate? If you have stage 3C disease or, God forbid, stage 4 disease. So if you're lucky enough to qualify for surgery, it's a good thing, and that is why low dose CT screening is available. You're for the most part going to be catching your early stage ones, maybe stage 2 tumors, which are curable with surgery. Radiotherapy, again, it's used in two scenarios. After someone's had a lobectomy, they have a positive node, positive margin, then you offer them radiotherapy. Or for a lot of patients that are not metastatic, but they have stage 3B, stage 3C disease, when you have lymph nodes involving your mediastinum or up above or below the clavicle, those are not surgical patients, unfortunately. You cannot take those lymph nodes out. So all you can do is do a combination of chemoradiation for 6 weeks and then give them immunotherapy for a year afterwards. But they still have a very, very high relapse rate. Chemotherapy, essentially all the way down to your stage 1Bs, patients are going to be qualifying for chemotherapy. Biologic agents, we really only use these in certain scenarios. You're going to use them now in the neoadjuvant setting prior to surgery. If you are a surgical candidate to downstage, you're also going to use them in the metastatic setting. So, as a general rule, if you can be offered surgery, yes, it's hard enough to have a lung cancer diagnosis, but when you get to meet with a cardiothoracic surgeon and they say, we're going to sign you up for a lobectomy, that's actually a good sign. So, and this is where there's true value in lung cancer screening, and I cannot emphasize how unfortunately underutilized it is, and it's partly because patients are very reluctant to undergo a CT scan for whatever reason. So, but absolutely a pound of prevention is worth a pound of cure after they stop smoking. So I'm a huge proponent of this.